Good morning, everyone. Thank you so much for joining us for an OrthoIllinois workers' compensation power lunch. We appreciate you taking the time over your lunch hour to spend a little time with us and learn a little bit more. We have Dr. Rowe, who's going to talk about common spine conditions in workers' compensation. I know how busy everyone is. I appreciate your time today. And without any further ado, I want to introduce Dr. Rowe. Dr. Rowe, thank you so much for taking time out of a busy clinic to talk to us today about common spine conditions and workers' compensation.
My pleasure. Greetings, everyone. This is my first such webinar, so apology in advance if this comes off really bad, but I suppose we should just dive right into it. So we're going to talk today about common spine disorders in workers' compensation cases. First, quick introduction. This is the Spine Center at OrthoIllinois. Dr. Sleva and Dr. Oakroy are the spine surgeons here at the Spine Center. Kelsey Montana is our nurse practitioner, and we have 3 excellent physician's assistants that work with us in the clinic and in surgery. So we are going to talk about a number of different items in the cervical spine, as well as in the lumbar spine. So the disc. This intervertebral disc is probably where most of the problems in the spine start. Disc disease is one of the names that's used to describe this process. And for many years, there were all sorts of theories as to what causes disc problems. Manual or physically demanding labor was a big one. Contact sports, obesity, smoking, car accidents or driving trucks, falling off or being kicked by horses. This comes up all the time for some reason. Or being dropped as an infant. I kid you not. So these are all like theories as to why people have disc problems. But in truth, good studies have come out in recent years to show that the real reason why people have disc problems is genetics. The way that this was proven was actually quite elegant. A study was done of identical twins in the US, Canada, and Europe. These are monozygotic identical twins. And so these are genetic copies of one another. And they did MRIs on the lumbar spine of these identical twins through their life. Sometimes one twin would be heavier than the other one. Sometimes one twin would do manual labor and the other one would work in an office. There were little differences between one twin who smoked, one twin that didn't. And the theory was that, well, the heavier twin would have a worse looking lumbar spine than the lighter twin. And what they found was no impact for occupational factors such as manual labor, no impact for recreational factors such as extreme sports, no impact on disc degeneration by smoking. Smokers had greater incidence of back pain, but no difference in disc aging or degeneration. Same thing with obesity. Whole body vibration was studied, no impact. Obesity was associated with greater amounts of back pain, but no change in the disc. So if you compare the MRI between the obese twin and the non-obese twin, they looked identical, down to like the little dots and streaks on the MRI. It was amazing. So this just refers to the state and aging process of the discs. This has nothing to do with back pain. Often the spine has very little to do with chronic back pain, just like the brain has very little to do with headache. Like you think it should, but it doesn't. And we know if you operate on the brain, you don't get rid of the headache. Back pain is like that. Chronic back pain has very little to do with the spine itself. But when you ask someone what caused the pain in your back, the answer is usually, I just woke up with it. Greater than 50% of people who have a herniated disc in the lumbar spine are unable to identify anything that actually caused it. They just woke up with it. It's amazing, but it's true, which really, sometimes people hurt their back and hurt a disc and hurt a herniated disc and have symptoms. Sometimes it just happens. So now that we understand that disc degeneration, which is really disc aging, well, it's genetic, and we can't change that, at least at the moment. Most lumbar conditions are self-limited, which is fortunate. And really, the best thing we can do to minimize these risks is good body mechanics, good bending and lifting technique, good hamstring flexibility, um, good core strength, but really, genetics can't be changed. So before we launch into some specific conditions, I just wanted to go over the anatomy of the lumbar spine. You see here on this diagram, we have the bony structures of the vertebral bodies and the intervertebral disc, which is comprised of the annulus fibrosus, which is the tough outer covering, and the nucleus pulposus, which is the softer, more cushiony type material. So when we talk about lumbar back pain, I think everyone knows that it is exceedingly common. Almost everybody has at least one episode of lumbar back pain in their lifetime, and many people are affected annually or episodically. It is the second most common reason to see a doctor after the common cold. And it costs a lot of money because of the impact to productivity. But as I said, most all of it gets better just with time. So the most common reason why people have lumbar back pain is a disc herniation in the lumbar spine. A lot of times people always say something like, oh, it's a lumbar strain, as if it was a muscular issue. True muscular injuries to the low back are exceedingly rare. So that's kind of a misconception. The pain of a herniated disc is in the muscle. So people think, oh, you must have torn a muscle or hurt a muscle. You didn't. What happens is when the disc herniates like this, it's like a jelly donut that gets squeezed, and some of the jelly pops out through the dough of the donut. So if enough jelly comes out such that it pinches a nerve, people will have pain down the leg, often referred to as sciatica. Sciatica is kind of an old-fashioned term that just talks about, that means pain in the buttock down the leg. So people think something's wrong with the sciatic nerve. There's nothing wrong with the sciatic nerve. The sciatic nerve is just the messenger. That's the pattern where the referred pain goes. If it's L5 or S1. If it's L3 or L4, it goes down the front of the leg. That's the femoral nerve. But regardless, when people acutely herniate a disc, some jelly comes out of the jelly donut. And what happens is you have to consider a plump jelly donut. It has a certain firmness to it. If you squeeze out some of the jelly, then you can imagine the donut gets a little floppy, a little loose. Well, in the spine, when a disc gets floppy and loose all of a sudden because it herniated, the central nervous system perceives this as instability, much as it would a fracture, like a broken bone. So what happens then is a very primitive reaction whereby the muscles that line the spine become very firm. They go into spasm as a way to splint and protect the area of instability, as if it was a fracture. But clearly, a disc herniation is not a fracture. This is sort of an overreaction to what happened. And so day by day, the alarm bells start going off until finally the back pain goes away, the spasm goes away. So that is why most back pain goes away on its own. People throw out their back or slip a disc. They're in bed for a day or two, and in a week, they're usually better, but they have the fear of the powerful, painful episode they just went through, which is a different matter. So MRI and lumbar pain rarely correlates, particularly in chronic lumbar back pain. And I just want to say, a lot of MRI reports will comment on degenerative disc disease. Again, this is a very old-fashioned term. It's not really a disease. Disc degeneration is synonymous with disc aging, much like gray hair would be degenerative hair disease, or wrinkles would be degenerative skin disease. I often get asked by patients, oh, is there arthritis on my MRI? Well, the answer is yes. You're 75 years old. Of course there's arthritis. What's a better question is the arthritis causing any of my symptoms? The answer is usually no, it's not, any more than gray hair or wrinkles. Arthritis of the spine, disc degeneration or desiccation or bulging, it's just age. We don't really care. So like this is someone like who had a horrible looking MRI. We see herniated discs, big bone spurs, slipped vertebra, spondylolisthesis. This patient had no back pain. Sometimes the people with a worse looking MRI have no back pain, and some people with a completely normal MRI have horrible disabling back pain. So that's what I mean when I say there is a very poor correlation between back pain and the MRI. And we know this because for years, people did surgery to treat back pain. We're talking axial lumbar back pain, nothing down the leg, just back pain. People had discectomies, laminectomies, spinal fusions. No one really got better because the back pain was never coming from the disc or the lamina. So back surgery got a bad reputation. Never let anyone touch your back. Back surgeries don't work. Well, if you're getting the surgery for back pain, yeah, it's probably a bad idea to have back surgery. There are very few conditions that back pain that can get better with back surgery, and most people don't have them. So like I said, brain surgery is a bad idea for headache. Back surgery is a bad idea for back pain. But understand, people use the word back pain very non-specifically. I've had so many patients come in with a chief complaint of back pain. I ask them, so where exactly does your back hurt? And they look at me and they say, my back doesn't hurt, but my leg is killing me. But the referral comes across as referred for back pain because whoever made the referral knows the problem is somewhere in the back. So they call it back pain, but really the back doesn't hurt. It's somewhere else. So again, talking about chronic lumbar back pain, the treatments are pretty standard. Proper lifting and bending technique, weight loss, core strength. Flexibility is really key. A lot of people think, oh, I have to strengthen my back, strengthen my core. That's not a bad thing, but as we age, it's actually much more about flexibility and posture and body mechanics. Physical therapy can be prescribed, pain management, stress management. I mean, there's all kinds of things that can be done. But as a surgeon, now I'll talk about some things that can be fixed, one of which is a lumbar disc herniation. We talked about how the jelly donut pops and the jelly comes out. And if it pinches a nerve and sends pain down the leg, depending on what nerve is pinched, different parts of the leg will hurt. That's why a good history and physical is so critical, because that will really help us identify what specific area in the spine is causing the pain. But again, most people get better. We follow this rule of 90s, which is to say 90% of people feel 90% better within 90 days, often much sooner than 90 days. Early on, we'll treat people with a Medrol dose pack. The steroids here do not act as an anti-inflammatory. We use them as a membrane stabilizer because the nerve roots often get very irritated. Steroids calm the nerves down in the lumbar spine and stop the inappropriate firing that causes much of the pain. After the steroids are done, we switch to anti-inflammatories. Physical therapy is useful in the beginning. Chiropractic care is very popular, and epidural steroid injections are used when people are having really severe pain. The therapy can help, but steroids work faster. That's what it comes down to. So here are the x-rays of someone who had an acute disc herniation. You can see she's leaning over way off to the right. That is called a sciatic scoliosis. That's not like the scoliosis many teenage girls get. This is a sciatic scoliosis because the body and the brain force the patient to lean to the right in order to try and unpinch the nerve that's pinched on the left. Here is the herniated disc at L4-5 that's pinching the left L5 nerve root. You can see on the rightmost slide, if you look at the left side, that circular structure just off the midline is the L5 nerve root. But on the left side, you can see that's the left side of the patient, the right side of the diagram. You can see that nerve is actually pinched so tightly by the herniated disc, and that this is that patient that could not stand up straight. So for a problem like this, if they fail to get better with conservative care, then we do a minimally invasive microdiscectomy, which is done through a half-inch incision using a series of dilators to open up a hole down to the spine. We work through a tube. I prefer a 14 millimeter tube, which is just over half an inch long, and it takes about 15 minutes, and the patients wake up with no leg pain. This little video should show us how the surgery is done. The patient is positioned prone. We drop down these dilators, which do not cut the muscle. They spread the fibers apart. And so that way all the anatomy is preserved. We go down and remove the herniated disc that unpinches the nerve. We pull out the dilator, and the patient heals with no scar tissue. So this is that same patient after surgery standing up straight. And so that's how we treat radiculopathy or pain down the leg from a herniated disc. I'll move on to discogenic lumbar back pain, this is one of those rare, and I mean rare, situations where patients will have true axial lumbosacral or lumbar back pain from the spine. In this case, this patient had an otherwise intact spine, but you can see the bottom disc, the L5S1 disc, is very collapsed. All of our discs collapse with time. That's why we get shorter as we get older. So that's normal. But if one disc collapses very quickly, then the bones have not had time to adjust and adapt and prepare to the loss of cushion. And if the bones start grinding and banging on one another too soon, too quickly, then we can see these reactive or inflammatory changes. If you look at the MRI on the far right, that is the inversion recovery sequence that looks for inflammation. Normally, bone has a very dark, almost black look to it. Inflammation shows up as white. And if you look at the signal changes around that L5S1 disc, you can see that it's turning white because of the edema and inflammation of the bone. In this situation, we can achieve a surgical cure of back pain with fusion. In this case, I prefer a minimally invasive fusion. It's an outpatient procedure done through 2 1-inch incisions. By separating the bones apart so they can no longer grind on one another, the pain generator is addressed, and these people actually have a cure for their back pain. I must stress, the vast majority of people who have back pain do not have this condition. Some people will have pain coming from the facet joint, which, as many of you know, are the little joints that line the spine on the posterior aspect. An acute facet syndrome can occur if someone has an extension event where they arch their back, and that can be painful, but usually gets better with time. Chronic facet pain can occur from true arthritic changes, often in the setting of instability, and if those changes occur, that can be treated with what's called a facet injection or a facet ablation. However, though facet ablation is used to treat many forms of back pain, it is this particular type of back pain where it is most effective. Sometimes people have a combination of facet or reactive changes in the facet joint with instability and pinched nerves, such as this patient. This patient has a pretty significant spondylolisthesis, or a slippage of L4 on L5. In addition to having pinched nerves and instability, you can see in that middle sequence how the L4-5 facet joint lights up. That again is from instability, where the facet joint is banging on itself because it's sliding back and forth unnaturally. In these cases, to stabilize them with screws and rods and a spacer and bone graft is very effective for treating not just their nerve pain, but their back pain as well. A moment talking about sacroiliac pain. This is an exceedingly common form of back pain that I see all the time, sometimes in the setting of other conditions, sometimes as a primary pain generator. People call it back pain, but it's not in the middle. It's just off to the side where the back and the buttock meet. On a thinner patient, there's often a dimple or a bony prominence where you can feel that joint, and it is tender in these patients. It can happen from an injury, either from a fall or some sort of lifting or twisting activity, and frequently they'll say they felt a pop in their back. And the pain comes from the sacroiliac joint. When it's really severe, it sort of radiates out into the buttock area, but it should not go down the leg, although that has been described. In a chronic setting, sacroiliac pain occurs usually in the setting of a gait change, meaning there's something that makes this person walk differently, and so that impacts the gait cycle, and so people will get a compensatory pain. Some people get greater trochanteric pain or bursitis. Some people get sacroiliac pain, and it's often, almost always, on the side where they have the pain. So this can happen from knee pain, foot pain, hip pain, or nerve pain down the leg. And what's interesting about sacroiliac pain is that it's one of the only back pains that hurts even when people lie down, so it affects sleep. It is because it is not a spinal pain, it is a pelvic back pain. And the pelvis is always under some sort of pressure, no matter what position you're lying on. And so often they'll be able to find a position that is comfortable, but then they roll over in their sleep, and then they wake up with back pain. But the treatments include rest, medication, physical therapy, and on occasion, sacroiliac joint injections, which are very effective for giving quick relief of this pain. And I usually do that if the pain is severe or if the patient cannot sleep because of the pain. As long as you address the underlying issue, the pain does subside. So that's my quick rundown of lumbar and lumbosacral conditions. We'll move into the cervical spine. How are we doing on time? Good. So cervical radiculopathy is another very common condition, which presents as pain on one side of the neck. And it will go down the arm, and depending on what nerve is pinched, different parts of the arm will hurt. Often accompanied by numbness and tingling, sometimes weakness, but it usually gets better with time, particularly if it's from a herniated disc. Most herniated discs do heal. Sometimes people have more of a bone spur that is causing the pain. These do not necessarily heal, although we can often get the pain to subside with conservative care, whether it's epidural injections, physical therapy, just time. But surgery must be considered if the pain persists or if the weakness, numbness, or atrophy really gets severe. So here's an example of a herniated disc. You can see the yellow arrow pointing out this piece of disc material that came out of the small jelly donut in the cervical spine off to the left side. That is pinching the nerve and will cause triceps and wrist flexor weakness and loss of the triceps reflex. In a situation like this, we can sometimes go in and do a minimally invasive surgery, just like in the lumbar spine, to remove the fragment, will relieve the pain, but only certain types of disc herniations are amenable to this treatment. Frequently, we will have to resort to a cervical fusion, which is an excellent surgery. Takes about 40 minutes, virtually painless, complete relief of the arm symptoms upon awakening. In this case, the surgery was done with a piece of allograft or a cadaver bone. Sometimes it must be done at multiple levels. Sometimes we use titanium cages, which can be very effective, especially with recent improvements in technology. Sometimes we can do a disc replacement. So this is a more recent technology. The first disc replacement was FDA approved in the United States in 2008. Subsequent models have been approved in 2012 and 2014. This was the first approved disc replacement in the United States, called the Prestige. The initial designs were fixed in place with screws, but were made of stainless steel, which was very inconvenient because subsequent MRIs could not be done. Now we use a titanium version, which is MRI compatible. And this is an example of how the disc replacement moves just like a normal disc. So if you were to cover up the implant and just look at the bony structures, you would not be able to tell which level had the surgery because the disc moves exactly like a normal human disc. So here's an example of a titanium disc that was placed at C6-7. The beauty of this surgery is that, number one, it is not a fusion. So there is no loss of motion. Fusion of any disc in the cervical spine sacrifices 8% of neck motion. Number two, because it is not a fusion, there are no restrictions after surgery. There is no need for a brace or a collar. People have no restrictions, so they can go back to physically demanding work in a day or two. Number three, because it is not a fusion, that eliminates the risk of non-union or pseudoarthrosis, which is what occurs when the fusion doesn't take. These patients can sometimes have pain and require additional surgeries to get the fusion to heal. And so theoretically, there's also the possibility that by preserving motion at a level, it minimizes the stresses above and below. Though that's not been conclusively proven because we don't have long-term follow-up far enough out, so far the preliminary data do seem to appear promising. So yeah, you can see here the neck moves just like a normal spine, no restrictions. This was actually a plastic surgeon who was operating later that week. Sometimes we can do the surgery at multiple levels, but we can only do it at 2 levels right now based on FDA restrictions. So talking about the cervical spine anatomy, there are the facet joints in the cervical spine as well. You can see them sort of in the center of the left left picture, these trapezoidal-looking structures called the lateral masses interdigitate with the levels above and below to form the facet joints. The diagram on the right shows you the zygoepiphyseal joints or the uncovertebral joints. These joints are unique to the cervical spine, and it is upon these joints that bone spurs will frequently form as we get older, and it is those bone spurs that will result in nerve root compression and radiculopathy. So sometimes people can have neck pain from the facet joints as well. These acute facet joints syndromes behave much like in the lumbar spine and usually get better with time. Chronic facet pain that won't go away is usually in the setting of arthritis with instability. Facet pain is usually on one side only, and people often complain of a muscle knot that they just can't get to go away indefinitely. They can treat it with rest and medication, therapy, even massage or injections. But the massage, it loosens things up, makes people feel better, but then within a number of hours or by the next day, they're kind of back to where they were. I must stress that axial, bilateral, or diffuse neck pain is not from the spine. In almost all cases, that is from the soft tissues, so we call it myofascial neck pain. But here's an instance of someone who had inflammatory facet arthritis. You can see on the leftmost x-ray there are some bone spurs and some ectopic bone forming in the soft tissues next to the spine. On the right side, you can see there is a subtle spondylolisthesis, but if you look at the MRI, again, it shows the arthritis that is isolated to the C4-5 level, and you can see on the right side there is lighting up of that facet joint. This we would call inflammatory reactive facet arthrosis, and these people have a very intense pain just on the one side, worse when they look to that side or look up. So, in cases where it does not get better with physical therapy and injections, and specifically radiofrequency ablation, often these patients have pain for a year or many years that just won't go away. Sometimes the pain can be intense to the point where it is disabling. The moment we get rid of the pain at that level by fusing that level, the pain goes away instantly. These patients are not candidates for disc replacement because disc replacement preserves the motion and it is the motion that hurts them. So these people must be fused. Thoracic outlet syndrome is another condition that I see very frequently, and it can masquerade as cervical radiculopathy because it presents with pain and numbness and tingling in the shoulder going down the arm. These people usually don't have a lot of neck pain. The symptoms begin in the shoulder and shoulder blade and often are more numbness and tingling than they are painful. It frequently occurs in the setting of an injury to the neck or shoulder, often after some sort of fender bender, low impact car accident. And often they are referred because it seems like a pinched nerve in the neck, but it is not. We can distinguish these symptoms because the symptoms are usually ulnar-sided along the medial aspect of the arm, forearm, and hand. Most radiculopathies are down the radial aspect or the thumb side of the arm and hand. Furthermore, the symptoms are worse at night when people lie down. Cervical radiculopathy feels better when people lie down. Symptoms are worse with arm elevation, when the arms are overhead. Cervical radiculopathy is often improved when people have their arm over their head. I'll frequently come into the patient's room when they're waiting and I'll see them on their phone with their hand on their head like this for relief. Vascular symptoms of thoracic outlet syndrome are extremely rare compared to the neurological symptoms that we're talking about now. And as you can see, there are many other diagnoses that can masquerade as thoracic outlet syndrome or cervical radiculopathy. So it is really incumbent upon the provider to do a very thorough workup to make sure it's not something else. Unfortunately, EMG does not often show or diagnose thoracic outlet syndrome unless there is actual nerve damage. Thoracic outlet is a very dynamic condition, and if people have symptoms from being in a position that pinches down on the brachial plexus, they just move their head or their shoulders or scapula, and then that relieves the pressure. So rarely is the brachial plexus compressed long enough or badly enough to cause nerve damage, and that's what the EMG detects. An X-ray can be helpful for looking for a cervical rib or a tumor, And the MRI rules out cervical nerve root compression. If someone has no nerve root compression on the MRI, then the next thought is, could it be thoracic outlet syndrome? So it's very much a clinical diagnosis, and these are the provocative maneuvers to look for it. So we treat this with physical therapy, and really the therapy has a lot to do with postural training. These patients have to learn how to pull their shoulder blades back and keep their head up to open up the thoracic outlet. And it often takes a long time before these people experience improvement, largely because it requires a lot of training and undoing bad habits when it comes to posture, which doesn't happen overnight. Surgery is very rarely required for this now, and it's hard to even find a vascular surgeon who will do this surgery. But they are out there. Fortunately, if the patient does a good job with their conservative treatments, they can avoid surgery altogether, which is good because it's kind of a big procedure. So, in summary, spinal disorders are frequent in the workplace, although I have to say in the last 21 years, I feel like they are less and less frequent because so often the really hazardous types of work, especially in the factory setting, have been eliminated. Now, a lot of times people just push a button. I must stress again, surgery is the last resort for all spinal conditions, but in the right setting, provided all the other conservative treatments have been tried, surgery is successful. So with that, I thank you.
Very good. Dr. Rowe, thank you very much for that presentation. Great. And I'm expecting a bunch of questions. So for more information about workers' compensation referrals or to learn more about our Fast Track program for injured workers, please go to our website at orthoillinois.com and click on Employers. In Algonquin, Elgin, McHenry, and the greater Chicagoland area, please call Paul Strandquist at 815-847-7088. In Rockford, North Central Illinois, you can call me, Bill Collar, at 815-847-7044. We have a lot of questions, Dr. Rowe, so we're going to try and get through as many of these as we can.
Okay.
One
away.
One of the questions, and we see this a lot in workers' compensation, when that patient initially comes in for low back pain, what are some of the things that you look for to indicate when an MRI should be ordered for that patient?
It's a good question. So, number one, duration of symptoms. If the symptoms are very brief, as I said, most people get better with time anyway. So, doing an MRI in that setting is often premature if the patient hasn't had symptoms for at least 4 weeks, 6 on the outside. The nature of the symptoms are also critical because if the pain is purely axial, there's hardly any value for an MRI, and I would discourage it. Even if people ask for it, it often is unrewarding and a waste of everyone's time and resources. If the symptoms, however, are down the leg, then the MRI becomes more helpful. And it's particularly helpful if the patient is in severe pain and in need of an injection. The injection can be done empirically without an MRI, or if you get the MRI, then a good pain specialist or surgeon should be able to direct exactly what kind of injection would be most efficacious. And of course, there are the red flags: severe pain at night or at rest, incontinence, suggestive of cauda equina syndrome, saddle anesthesia or paresthesia, weight loss, things like this that could suggest either cauda equina syndrome, fracture, tumor, things that are time sensitive. In those cases, an MRI is absolutely mandatory.
Now, for those patients who have gone elsewhere and they walk in with the MRI that shows a lot of degenerative conditions, potentially asymptomatic things that are found on that MRI, what are some of the techniques that you use to differentiate what may be work-related versus what is asymptomatic and the patient is focusing on because the MRI has a long list of things that it finds?
Yes, I know. The MRI reports often make it look like someone's dying. But it is a good question, and truthfully, that gets down to the issue of causality, right? So I would say that if someone has an acute or subacute disc herniation, we can usually tell, looking at the MRI, if something happened recently. And if that recent appearance of the disc herniation fits with the chronology of the patient's injury, and then we go in with surgery and then we confirm, oh yeah, this is an extruded disc fragment, well, that usually is the strongest evidence of causality if there was the history of an injury and the mechanism fits. Sometimes people just have underlying arthritic or age-related changes that were quiescent, and then some sort of injury activates this, flares it up. Often we can get it to calm back down, but if it does not calm down, then we would call that more of a pre-existing condition that was exacerbated by injury. But clearly, if people have pre-existing degenerative changes everywhere, and there's really no single area that would explain the patient's symptoms, well, then we say that this is not amenable to a surgical cure.
Got it. Very helpful. I'm sure you've never seen that patient that walks in with the MRI that has a whole list of things that it's found, and they're convinced that those are symptomatic.
I'm waiting for the patient that doesn't.
Susan's got a question. At what point post-fusion surgery, doesn't say what fusion, but at what point post-fusion surgery is it appropriate to determine fusion success or lack thereof?
Well, it depends what you mean by success. Clinical success isn't based entirely on whether the patient's had symptom resolution. Fusion success is a more complicated matter. So a fusion has to result in solid healing across a level that used to move, much like two ends of a broken bone have to knit together to become solid. If the fusion is not solid, meaning it's an unsuccessful fusion or a non-union or a pseudarthrosis, these are all synonyms, well then what matters is the patient better? The vast majority of pseudarthroses or non-unions are asymptomatic. So if the patient's doing great from surgery and had complete symptom resolution and has a non-union, then we don't have a problem. The only time we worry about unsuccessful fusion or non-union is when it is symptomatic. And usually those patients present with pain, with or without pain down the leg. It's usually more pain in the back or the neck. In the neck, they present with suboccipital headaches or interscapular pain as well that are worse with activity, better with rest. The key is to identify that is the pain generator as opposed to saying, oh, your headaches are migraine. But migraines usually don't follow that pattern. In the low back, it's usually back pain. And these pains in the cervical spine will not occur before 3 months because it takes that long for the instrumentation to get loose. In the lumbar spine, it takes longer for the fusion to heal, so it takes longer for us to be able to make the diagnosis in the lumbar spine. And usually in the lumbar spine, to make the diagnosis, we need to either see loose screws or broken screws, or in some cases, we can see reactive changes through the disc space or resorptive changes on CAT scan. So again, it becomes a very clinical diagnosis, but fortunately, since the advent and popularity of interbody fusion in the lumbar spine as opposed to just screws and rods, the incidence of non-union has become vanishingly low, and so too has the incidence of symptomatic non-union.
Jesse has a couple of questions. One of them is the $64,000 question, which is, when and how do you determine whether or not a condition is work-related? And then on top of that, on the employer side, what are some things that an employer can do to help to minimize aggravation of an existing back claim or injury?
Yeah.
Maybe two $64,000 questions.
Yeah, I'll need the check written out to my wife. But anyway, that is really hard to answer in specific terms. In general terms, I would say, like I said before, the chronology of the onset of symptoms and the nature of the injury need to make sense with the MRI findings. So that's a pretty general starting point. It After that, it comes down to really not even really what clinically or medically makes sense. It seems to come down to more what like shifts in the workers' compensation field. Now, it's become increasingly difficult for patients to get workers' compensation approval. I mean, it's night and day compared to back in the day, and I'm sure some of those changes were necessary. But nowadays, unless like something large falls on a patient and it's witnessed by at least 20 people, the claim will be denied. It just seemed that's my personal observation. But in terms of what can be done to prevent injuries in the workplace, that's really tough because I think much of that has already been done. Like I said, nowadays people just push a button, whereas back in the day, they would have to like get into all these weird, dangerous, uncomfortable positions. Some jobs are inherently taxing to the body, and I think those they just accept the risks and understand that some percentage of people will get hurt because there's only so much you can do in a physically demanding job to minimize those risks. But yeah, beyond common sense, I believe that most workplaces have been made as safe as possible, and the ones that haven't, there's just no way to do it.
Can you comment a little bit? This is from Debbie. Can you comment a little bit on SI joint fusion? What your thoughts are on that procedure?
Not a fan.
Not a fan.
I'm just not a fan. The data that have been published and made available really do not present a great testimonial for the technology. And I think it is multifactorial. Number one, the vast majority of sacroiliac pain can be managed conservatively. And so much of the sacroiliac pain occurs because of something underlying in the ipsilateral lower extremity. So with physical therapy, with proper modifications, I mean, I would say 8 out of 10 people with chronic sacroiliac pain have extremely weak hip abductors. So their gait is kind of wobbly. And so compensatory pain is inevitable. And I tell these people, what I'll do is like they'll have 4 out of 5 motor grade in their hip abductors. I can just push their knees right together in the seated position, despite their maximal effort. And then I turn to their spouse or whoever came with them and I say, do you mind? And I try to push their legs together and I can't even budge them. And I say to the patient, when you get to that point where I cannot push your legs together, your pain will go away. It's just a matter of strengthening hip abductors. And that can be done at home on, lying on your side doing clamshells or with a TheraBand. It's easy, but people have to do it. So sacroiliac pain is very effectively treated with things like that. Or you can get a sacroiliac fusion by putting 3 bolts across the joint. But then you're just going to shift the stresses to the level above, L5S1, or the level below, which would be the hip joint or the other sacroiliac joint. Not a fan.
Got it. I feel as though this question is going to get a solid, it depends. But one of our attendees asks, what do you feel about chiropractic care for lumbar pain immediately? And I think the best part of this question is how many visits before you determine whether or not it's going to be effective or helpful?
That is a good question. I think chiropractors help a tremendous segment of the population who have these issues. And I think, like doctors, there are good doctors and there are good chiropractors and bad ones. I think that they are more easily accessible and they're better at talking to patients and spending time with them. And the effects are often immediate. So you can go to a chiropractor and if they can relieve the spasm in your back and get you out of bed and walking, it's probably better than taking narcotics. And like I said, most conditions get better on their own. So the chiropractor, Voltaire, this is going to sound so pompous, but Voltaire said, Medicine is the art of entertaining the patient while the body heals itself. I saw it on a bumper sticker. So, uh, so yeah, whether it's chiropractic or physical therapy or pain management, I mean, patients get better, right? So it's a matter of keeping them comfortable, managing their anxiety, and just giving them time for things to heal. As to how long it will take before you know whether or not it's working, I mean, that's so case by case basis, right? I think that if you've gone for a week or two and you're not seeing any improvement, then maybe it's time to change lanes.
Got it. I loved your slide, for lumbar disc herniation, 90% of patients get better in 90 days.
hmm
What are your strategies for the 10%?
Oh, well, if they get out to 3 months, usually what happens is people have a herniated disc and they're in a lot of pain. It's terrible. They go to the ER, they lie in bed, um, and then it starts to get better. And some people just get better until the pain is gone. Some people never get better. They're just in agony. They need to get admitted for pain control. Most people, they get better to some extent, and then the symptoms sort of plateau. And they stay that way. They don't get better, they don't get worse. And the patient sort of modifies their activities. They stop doing anything that aggravates the pain. So that usually helps the symptoms too, but that's not really improvement, right? That's just stopping activities. That's not sustainable. And then it really depends on where that plateau is. Is it 8 out of 10 plateau or is it 2 out of 10 plateau? The 8 out of 10 plateau, they sign up for surgery. The 2 out of 10, they kind of think about it. They say, you know what? It's not that bad. I can do everything I need to do. I'll just give it time.
Roxanne has a what looks like a pretty specific question, so I'm going to try and make this a little bit, or I'll read her question, then I'm going to try and make it a little more general. So her question, if a patient has had 2 microdiscectomies at L4, L5 without any relief of pain, MD now recommending TLIF, she says, L3 to S1. Do you feel that surgery would be appropriate from L3 to S1 despite previous surgery only L4, L5? And I guess my more general question for you would be, how do you, if you're seeing a patient as a second opinion that has previously had back surgery and it has not been successful, what do you as a surgeon use in your toolbox to determine if an additional surgery is warranted?
Sure. Well, for starters, I would start at the beginning and just confirm that L4-5 is the pain generator. If people get no relief after a discectomy, it's a little strange. It suggests that maybe the pain's not coming from that herniated disc. Often they have foraminal stenosis that is unrecognized or at that level or an adjacent level. And so if the pain generator is not identified, well, then no surgery is going to help. So once that's clarified and we're confirmed that, yes, L4-5 is the symptomatic level, then I would fuse L4-5. I am not a big fan of fusing additional levels that are asymptomatic unless it's obvious that they will become symptomatic shortly thereafter. I have noticed a trend in our field of fusing more and more levels, probably correlating with declining reimbursement. But 3-level lumbar fusions, in my experience, are exceedingly rare, at least rarely necessary. Let's say that. Sometimes, but rare.
Got it. I know we're pushing up against afternoon clinic, so we've got a couple last questions I want to try and get in. Mary's question, very general, but thoughts, opinions on spinal cord stimulators?
Well, I don't do them. I know some spine surgeons do them. I do not. But I think that it is a last resort. I think that most good pain specialists will not offer it as an option if the possibility of surgical cure is there. This is really something to be considered only when surgery is not an option, whether because the patient is too old or too sick or too scared, or if the patient has pain that cannot be explained and therefore cannot be fixed with surgery, or if the patient has had surgery and just didn't get better, which fortunately is rare.
Got it. Got it. We're going to try and squeeze one more question in here, and I've got a bunch left, so I'm going to try and pick one here. What do you feel in general would be the typical recovery time for someone that is being treated for radiculopathy? Doesn't say spine, it doesn't say cervical
Pre-op,
or
post-op, discectomy, fusion.
Yeah, I figured that would be a big old depends. So I guess I'm gonna change course on that one a little bit. We see a lot of patients that come into our Injury Express that have shoulder pain caused from a suspected work injury. And as they're presenting their symptoms, they have radicular symptoms down their arm.
Mm-hmm.
I think it's related to that question. How do you, as a spine surgeon, begin to differentiate rotator cuff from radicular symptoms from the C-spine when those can kind of overlap?
Sure. Yeah. This is exceedingly common, particularly with radiculopathies at C5 or C6, because these are the two nerve roots that innervate the rotator cuff. If the rotator cuff gets weak or dysfunctional, then the subacromial space becomes a pain generator. So these people will have pain with reaching behind them, overhead activity, tenderness in the anterior acromion. So this often coexists with cervical radiculopathy and vice versa. If people have numbness and paresthesia all the way down the arm, that is not the rotator cuff or shoulder. If they have weakness in innervated muscle groups of the nerve root that is suspected, well, then that is not shoulder. Although pain inhibition in the shoulder will affect the ability to test the biceps, triceps, external rotators, and deltoid. If people have a positive Sperling sign, then that's another finding that would be more specific to a radiculopathy. And so then it's, because the two symptoms often coexist, then it becomes a matter of identifying which is worse. Is it their shoulder? Is it the neck? Sometimes the neck starts, and then later on in the course of care, the shoulder starts to become painful. And in those cases, if we decompress the nerve roots, the rotator cuff starts working better, then often the subacromial symptoms go away. If the subacromial symptoms, shoulder symptoms, have taken on a life of their own, that can need subsequent treatment. But they do better with conservative care of the shoulder after the nerve roots have been decompressed.
Everyone who joined today, thank you very much. Some amazing questions. We really appreciate everyone's participation. I'll leave the QR code up here for about another 30 seconds. Thank you so much for your time. Dr. Rowe, wonderful. Thank you very much for participating in this and answering these questions. If anyone has any questions, concerns, issues with the survey, please email me directly. My email is billc@orthoillinois.com. Thank you very much again for joining us. I hope you have a wonderful afternoon, and happy pre-Friday.